In this lesson, you will learn more about syphilis, HIV, and chancroid. You will learn about transmission, staging, signs and symptoms, adverse outcomes, and treatment options. You will also learn to recognize some common STIs and be able to describe the reporting requirements for providers. Now let's talk about syphilis. Syphilis is caused by the bacterium Treponema pallidum, which is a tiny little corkscrew-shaped spirochete. Syphilis infections are characterized by two symptomatic stages called primary and secondary syphilis. In the primary stage of syphilis, a painless lesion, also called a chancre, will appear at the site of infection. So if someone is exposed to syphilis through receptive vaginal sex, the lesion will appear somewhere in the genital region, likely in the vaginal canal. Since the lesion is painless, persons who are a receptive sex partner may not know that they have a lesion unless they happen to get an exam during their symptomatic period, which would last a maximum of 5 weeks. There may be some localized lymphadenopathy near the lesion. So if you have a penile lesion, you might see swelling around the lesion or in the lymph nodes that are near the groin. If you have an oral lesion, you might see swelling in the nodes near the throat. A lesion must be present at the time of testing for a person to be considered a primary case. When a person progresses to secondary, the symptoms will become more diffuse throughout the body. You might see a generalized rash. Rashes on the hands and/or feet are a big indicator of syphilis. Pretty much the only things that cause rashes on the hands and feet are contact dermatitis, hand, foot, and mouth disease, and syphilis. Alopecia, or patchy hair loss, is another possible symptom of secondary syphilis. Some people will develop a fever. Others may have a white cauliflower wart-like lesion called condyloma lata or C. lata appear. C. lata is typically painless. Some people may have some painless lesions appear in their mucous membranes, including their mouth, vagina, and/or anus. These lesions are very infectious, so you can be exposed to syphilis by coming into direct physical contact. Other people may experience weight loss, muscle aches, fatigue, and other nonspecific symptoms. The primary and secondary stages of infection are important because symptoms during those stages remain the only time when the infection can be transmitted. The symptoms of primary and secondary syphilis are usually painless and will go away on their own without treatment. Due to the nonspecific nature of these symptoms, many people will pass through these stages without even knowing they have been symptomatic. The other problem is people can experience adverse outcomes at any point in their infection, even decades after their initial exposure, unless they receive appropriate treatment. Syphilis is passed by coming into direct contact with a syphilitic lesion, which appears during the primary stage, or by coming into contact with the mucus patches and C. lata lesions that may be present in the secondary stage. Since lesions appear at the site of infection and in the mucous membranes, the mouth, vagina, and rectum, typically we see syphilis transmitted through vaginal, anal, and oral sex. As with many STIs, pregnant persons can pass syphilis onto their baby at any point during pregnancy and delivery. Syphilis can invade the central nervous system, or CNS, and spread to the eyes, resulting in vision problems, the ears resulting in hearing loss, and the brain resulting in difficulty with coordinating muscle movements, numbness, paralysis, and dementia. Syphilis can cause pregnant persons to miscarry or have a premature delivery resulting in low birth weight. Stillbirth and infant death shortly after birth are possible and occur in 7 to 10% of congenital syphilis cases. For babies that survive delivery, they can still develop life-threatening symptoms. Syphilis can impact bone development, so one of the things we look at in infants with syphilis exposure is abnormalities on long bone x-rays. It can also lead to problems with the teeth. And of course, all of the adverse outcomes in adults can also be observed in babies. So blindness, deafness, motor problems, and neurologic problems can develop. Some babies with syphilis exposure will be born very symptomatic. Others will look perfectly healthy, but could go on to develop life-threatening symptoms later on. Some symptoms of congenital syphilis may not manifest for up to 40 years. The good news is all of this can be easily prevented through timely and appropriate treatment. So it is really important that we monitor both parents and infants with syphilis exposure to ensure that they receive the recommended treatment and follow-up. Ideally, pregnant persons should initiate appropriate treatment more than 30 days prior to delivery to reduce the likelihood of delivering a baby with congenital syphilis. And we still want to monitor babies with syphilis exposure after delivery to make sure they don't develop signs of syphilis. For this reason, it is required in Arizona to test persons at the first prenatal visit, early in the 3rd trimester, and again at delivery. Remember, syphilis causes premature delivery. So if you see someone testing positive in their 3rd trimester, they'll need to get connected to treatment as soon as possible. As mentioned previously, syphilis is curable, and the earlier it is detected, the shorter treatment options can be. Persons who are staged as primary, secondary, or early non-primary, non-secondary, which just means that they've been infected in the last 12 months and are asymptomatic, can be treated with penicillin. Bicillin LA is a brand name for penicillin, and it is specifically a long-acting variation of penicillin. So it stays in your system for a longer period of time than other forms of penicillin. For persons who are known to be infected over a year ago, or persons whom you cannot prove they were infected in the last year, they will be staged as unknown duration, latent, and have to receive 3 doses of bicillin at 7-day intervals. Now let's take a closer look at penicillin. The penicillin injections are administered through an intramuscular injection in your glutes, i.e. your butt muscles. Most of our health departments carry penicillin 1.2 million unit dose injections. So they typically administer 2 shots to get the full 2.4 million unit dosage. And these shots are painful. A lot of clients will experience flu-like symptoms and soreness after their injections, which can make sitting down uncomfortable. Some people may have a stronger reaction to the treatment called a Jarisch-Herxheimer reaction, or JHR. JHR typically appears within the first 24 hours, but the symptoms usually go away in a couple of hours. JHR can include fever, chills, rigors, nausea and vomiting, headache, tachycardia, hypotension, hyperventilation, flushing, myalgia, and exacerbation of skin lesions. JHR reaction is not the same as an allergic reaction. Signs of a penicillin allergy include tingling, rash, itching, stomach upset including nausea, diarrhea, and constipation, body aches, sleep disturbance, ringing in the ears, and mild wheezing. More severe reactions include signs of anaphylaxis, which could be a swollen face, rapid heartbeat, tightening of the chest, weak pulse, low blood pressure, shallow rapid breathing, rash, hives, blisters, nausea, vomiting, shock, feeling lightheaded or faint, breathing difficulties such as fast, shallow breathing, wheezing, clammy skin, confusion and anxiety, collapsing or losing consciousness. Penicillin is one of the most commonly reported drug allergies, where about 10% of the population will report a penicillin allergy. Only about 1% of the population is truly allergic. There is no alternative regimen for treatment of any stage of syphilis in pregnant persons. If a pregnant person has a penicillin allergy, they will need to be desensitized. Desensitization needs to be coordinated with a medical provider. Desensitization is when smaller doses of penicillin are given in a controlled manner under the supervision of a medical provider until the patient can tolerate a full dose. We'll talk more about how to manage penicillin allergies in a later section, and we will explore treatment in greater detail and how to navigate penicillin allergies toward the end of this course. HIV, or human immunodeficiency virus, is a virus that attacks the body's immune system. If HIV is untreated, it can lead to AIDS, acquired immunodeficiency syndrome. There is currently no effective cure. Once people get HIV, they have it for life. With proper medical care, HIV can be controlled. People with HIV who get effective HIV treatment can live long, healthy lives and protect their partners. There is no definite way to tell whether or not someone has HIV by looking at them. Symptoms of acute HIV infection happen within the first 2 to 4 weeks after acquiring HIV. About 2/3 of people will experience fever, chills, rash, night sweats, muscle aches, sore throat, fatigue, swollen lymph nodes, and mouth ulcers. This early stage of HIV is one of the most infectious because the virus is rapidly replicating and there is a very high viral load. There are usually no symptoms during the chronic HIV stage. However, the virus can still be transmitted. Symptoms of AIDS vary greatly because the symptoms are based on the opportunistic infections acquired. Some common symptoms include severe rapid weight loss, night sweats, pneumonia, thrush, extreme fatigue, chronic diarrhea, and neurologic disorders. AIDS is also a highly infectious stage because of the very high viral load. Persons living with HIV who achieve and maintain an undetectable HIV viral load cannot transmit the virus to others. To achieve and maintain an undetectable viral load, a person living with HIV must adhere to their antiretroviral therapy, ART, under the guidance of their medical provider. Research now shows that people who achieve an undetectable viral load while on HIV treatment have effectively no risk of transmitting HIV to their partner. We refer to this as undetectable equals untransmittable, or U equals U. For transmission to occur, the HIV in the specific fluids previously outlined must get into the bloodstream of an HIV-negative person. The most common routes of transmission happen through a mucous membrane found in the rectum, vagina, mouth, or tip of the penis, open cuts or sores, or by direct injection. Other less common routes of transmission are lateral transmission, from a mom living with HIV to a baby during pregnancy, delivery, or breastfeeding, and skin punctures with an HIV-contaminated needle or sharp object. There have been instances of HIV transmission by oral sex, receiving blood products or tissue or organ transplant, and contact with HIV-infected fluids, particularly blood-contaminated body fluids, through skin breaks, but these are rare. For example, there is a possibility for transmission through deep open-mouth kissing when both partners have bleeding gums or other oral sores, and blood from the partner with HIV gets into the bloodstream of the partner without HIV. Infection with any STI increases the risk of acquiring HIV due to the presence of a sore or inflammation that may allow infection with HIV that could have been stopped by intact skin. The HIV epidemic has come a long way since its beginnings as an unknown quote-unquote cancer to a chronic and manageable illness. However, misinformation and a lack of knowledge around HIV continues to perpetuate stigma. One way to help educate and shift these attitudes is to shine a light on some of the myths around HIV today. You can't catch it by breathing the same air, touching a toilet seat or door handle, drinking from a water fountain or cup, hugging, kissing, or shaking hands, sharing eating utensils, or using exercise equipment at a gym. The natural course of an HIV infection includes 3 stages: acute HIV, chronic HIV, and acquired immunodeficiency syndrome, or AIDS. Although there is no cure for HIV, there is treatment that helps prevent you from progressing from one stage to the next. One of the main goals of HIV treatment is to reduce the amount of HIV found in a person's bloodstream. This is a short list of adverse outcomes of HIV. AIDS is the most severe phase of HIV infection. People with AIDS have such badly damaged immune systems that they get an increasing number of severe illnesses called opportunistic infections. People receive an AIDS diagnosis when their CD4 cell count drops below 200 cells per cubic millimeter, or if they develop certain opportunistic infections. People with AIDS can have a high viral load and can be very infectious. It is a life-threatening condition that damages the immune system by interfering with the body's ability to fight infection and disease. However, persons living with HIV who regularly engage in their HIV healthcare may have earlier detection of complications, are able to manage medication side effects, and develop skills to maintain overall optimal health. Engagement with an HIV medical provider or case manager may lead to more favorable coping mechanisms, skill development for pertinent discussions with partners and loved ones, and/or a necessary social service or mental health referrals. Antiretroviral therapy, or ART, is a combination of HIV medication used for the treatment of HIV. ART can't cure HIV, but it can help people live longer, healthier lives. PEP, post-exposure prophylaxis, is an ART regimen that may prevent HIV infection when used within 72 hours of an HIV exposure. PrEP, pre-exposure prophylaxis, is an ART regimen for people vulnerable to acquiring HIV. It prevents a person from getting HIV when taken as prescribed. ART, including PrEP, cannot prevent other STIs. It is specifically for the management and prevention of HIV only. Interpretation of treponemal and non-treponemal serologic tests for persons with HIV infection is the same as for persons without HIV. However, persons living with HIV and who have early syphilis might be at increased risk for neurosyphilis. They may also have higher rates of atypical serologic response, i.e. high, low, or fluctuating titers, even when adequately treated. For this reason, persons living with HIV and who have a dual syphilis diagnosis should engage in more frequent serologic tests. There is an increased risk of HIV transmission when syphilis symptoms are present. Studies have shown that syphilis increases the HIV viral load, and a sore or inflammation from syphilis may allow infection with HIV that could have been stopped by intact skin. Finally, let's take a moment to explore chancroid. Chancroid is a reportable STI in Arizona. However, it is incredibly rare. It is characterized by a painful genital ulceration and inflammatory inguinal adenopathy. Every so often, we get a report of suspect chancroid, and about once every 5 to 10 years, it does meet the definition for a case. To meet the probable definition, the case must meet the clinical description be negative for syphilis at least 7 days after ulcer onset, and they must be negative for herpes, or the ulcers must not be typical for herpes. To be a confirmed case, it must test positive for H. ducreyi, sometimes pronounced H. ducreyi. Local labs do not test for chancroid, but ADHS has the ability to ship a suspect specimen to CDC for testing, if prior approval from our CDC contact is received. In 2019, ADHS submitted a suspect specimen to the CDC lab for chancroid testing, and even though it was negative for chancroid, it met the probable definition because it was also negative for syphilis and herpes, and it matched the clinical description. Chancroid is curable when treated with one of the following regimens from the CDC STI treatment guideline: azithromycin 1 gram orally, ceftriaxone 250 milligrams intramuscularly, ciprofloxacin 500 milligrams orally twice a day for 3 days, or erythromycin 500 milligrams orally 3 times a day for 7 days. In this lesson, we discussed the routes of transmission for syphilis and HIV, factors that may make transmission easier, and possible adverse outcomes. We also discussed how signs and symptoms aid in the staging of diseases and how they are related to the ease of transmissibility. Lastly, we discussed treatment options for syphilis, HIV, and chancroid. Syphilis and chancroid are curable, but HIV is not. However, HIV can be manageable and prevented with ART.